So my name is Megan Feiner. I'm an M2, part of SNaHP, and we are kind of going to go over issues in the healthcare system, but this slide just pays homage to the slides that we pulled a lot of information from, which was the single payer update at the 2022 SNaHP Annual Summit. Today we're going to be covering the state of affairs in the current system and the effects of this broken system. And as a quick look ahead to the rest of the week, Mike over there will go over the 2022 Medicare For All Senate bill, and more importantly, he'll cover why the solution is fixing the problem that we posed today. And on Thursday, we will be myth busting the major arguments against universal health care and also ending with ways to get involved in SNaP. So currently the US spends more money on healthcare than many other countries with universal healthcare systems. And as you can see in the chart, the US's national per capita health expenditure has continually increased. There's record high spending. In 2020, over $12,000 was spent per capita and $4.1 trillion in total, which is the largest increase between years that we've seen. And just kind of explaining national per capita health expenditure is the amount that each country spends on health for both individual and collective services. And it's not so much, while it's important to kind of identify how we spend as a country, it's also important to see how it affects individual people. And as you can see on the right, annual premiums for families of 4 are increasing over the decades. And in 2020, it was a total of $21,000 with the worker contribution to that increasing. Additionally, the US spends more money on healthcare than many other countries with universal healthcare systems. The last data point was in 2018 on this graph, and the US was spending 16.9% of its GDP on healthcare, but the latest data suggests that that number has increased to 19%. And so you might be thinking that more spending is better healthcare, right? Well, you'd be wrong. So as you can see, we spend significantly more, but perform significantly worse. And to try to break that down and try to show where that results. So you can kind of see life expectancy is much lower, well, not much, but definitely lower compared to other OECD countries. And kind of explain OECD, it is countries of similar organizational and economic development. So they can be compared because they're at similar levels of kind of where their countries are at. And then you can see that the US is leading the world in infant mortality, which is also not great, that if people brought into this world are dying at a greater rate here, that doesn't bode well for our country. Again, you can see that maternal mortality rate is also high and increasing compared to other similarly performing countries. And while maternal mortality rate is a very complex issue, it is like a key indicator of a health system, and not taking care of young mothers means that you are doing something wrong. And we are the only country that has actually increased over the last 25 years. And so, again, this is just showing the number of uninsured and the uninsured rate among the non-elderly population. And you can see following the enactment of the ACA in 2010, when coverage for young adults below age 26 and early Medicaid expansion went into effect, the number of uninsured people and the uninsured rate began to drop. When the major ACA coverage provisions went into effect in 2014, the number of uninsured and uninsured rate dropped dramatically and continued to fall to 2016, when just under 27 million were uninsured. But however, this uninsured rate increased in 2019, continuing a steady upward climb that began in 2017. And the uninsured rate in 2019 ticked up to 10.9 from 10.4 in 2018. And the number of people who were uninsured grew by more than 1 million between the 2 years. And this number has continued to rise, especially during the COVID-19 pandemic, which is a time when people needed health insurance the most, arguably. And You can see that the leading reason for being uninsured was that coverage was not affordable. An honorable mention being that second place was that people were not eligible, which is also crazy considering that everyone should be eligible for health insurance. And Medicaid eligibility for adults varies across states and is sometimes limited. As of October 2020, 39 states, including DC, adopted the Medicaid expansions for adults under the ACA. But in the states that have not expanded, Medicaid eligibility remains limited for adults. Additionally, the state renewal policies and periodic data matches can make it difficult for people to maintain Medicaid coverage. And additionally, millions of poor uninsured adults fall into a coverage gap because they earn too much to qualify for Medicaid, but not enough to qualify for marketplace premium tax credits. And so 28% of US adults who have health insurance through their employer were underinsured. And what underinsured basically means is that you have insurance, but it costs too much to kind of use your insurance. And to qualify, that means that your annual out-of-pocket expenses are greater than 10% of your income, or if your income is under 200% of the federal poverty limit, that means that your out-of-pocket expenses are greater than 5% of your income. Or it can also mean that the deductibles are greater than 5% of your income. It's also important to note that deductible is a unique concept to the United States for the most part. And deductible, as most of you probably know, is kind of the amount of money you have to pay for your insurance to kick in. And in a couple slides, you'll see that this cost is also increasing. About 28% of adults who receive their healthcare coverage from their employee-sponsored programs were underinsured. And additionally, people who bought their plans on their own through the individual market or marketplaces were more likely to be underinsured, with 42% reporting a lack of adequate coverage. And so this kind of causes problems in two ways. First is the problems in getting care. So 41% of underinsured adults said they delayed needed care because of costs, compared to 23% of people with adequate insurance coverage. And there's also difficulty paying medical bills. So almost half, or about 47% of underinsured adults report medical bill and debt issues, which is nearly twice the rate as those who are not underinsured. And again, just some more figures to kind of show where we're at. So only 8% of adults 35 and older get their recommended preventative screenings, which does not bode well for preventative care, which is typically less expensive to treat. Preventative care is typically less expensive than once you already have been diagnosed and are trying to treat and manage an illness. So it's ideal if people are getting preventative services. And additionally, you can see that 25% over the age of 55 were unable to take medications because of their cost. And while this is also an issue in Canada, to not say that every other system is perfect, it is significantly worse in the US. And so just kind of looking at effects of COVID, a recent study found that 1/3 of COVID-19 deaths were, and about 40% of infections were linked to a lack of health insurance. And for every 10% increase in a country's uninsured rate, the researchers found a 70% increase in COVID-19 infections and nearly a 50% increase in deaths from COVID. Another absurdity of our system was laid bare by COVID-19, and this is the fact that more than half of Americans depend on their insurance provided through their job. And because of this, Americans are always at risk of losing coverage through job loss, especially during an economic downturn, and even more so during a downturn caused by a global pandemic. And around 22 million Americans lost their job due to COVID-19, meaning millions also lost their health insurance during the global pandemic. And compounding the overall uninsured and underinsured rates is that many industries deemed to be essential among the highest uninsured rates for employees. So as you can see, in uninsured workers across several industries such as agricultural, meatpacking, construction, which are typically deemed essential for the functioning of our country, have high uninsured rates. And this kind of boils down to, as I see it, the people who need and are on the front lines are kind of suffering a lot because they're uninsured, and we're not really valuing people as essential when we call them essential. And so why is our system so broken? This image kind of sums it up. It's a mess, and there's many reasons as to why our healthcare system is so broken. Some of the contributing causes are a fragmented system with a mixture of public and private insurance when there's thousands of different plans and networks. This results in extreme administrative waste because we have to kind of balance and work between these systems rather than just having one system. Also, private insurance prioritizes profit over patients. And so their bottom line is to make money, not really provide healthcare and treat people and make sure people are healthy. And it also is incredibly expensive with or without insurance to have healthcare. And again, this just pays and reiterates the point that we are underperforming and also expensive. And as I mentioned, I said that the deductible rate has been increasing, and that's shown here that workers' earnings have not really increased that much, but deductibles have. And on the other side of the screen, you can see that 2/3 of bankruptcy filers cite either medical bills or illness-related work as their reason for filing. And so in addition to being underinsured, a lot of patients experience surprise billing, which is also a contributor to medical debt. So surprise medical bills may occur for several reasons. In some cases, particular services such as lab tests or products such as prescription drugs may not be covered by a health plan. Care received before meeting the deductible or high cost sharing requirements may also surprise consumers if they're not aware that they have to do that. In other cases, healthcare providers may be out of network for a plan. As you can see, of the 41% who had a surprise bill, 19% were surprised by a bill for an out of network provider. For example, sometimes when you go into surgery, the surgeon will be in network, but the anesthesiologist will be out of network, and no one would really think to check that because it doesn't make sense that they would be different in coverage. And charges for services may only be partially covered or not covered at all, depending on the type of insurance and benefit design. So people might think that a service is completely covered when it's not, and then end up with, again, a surprise bill. And so many US adults have trouble affording healthcare costs, and this is even true for people who have insurance. Among those under the age of 65, uninsured adults are much more likely to say affording healthcare costs is difficult at 85%, but even 47% of adults with insurance still agree it's hard to afford. And the slide also serves as a good transition to our next point. An effect of the broken healthcare system is health disparities. And as you can see, at least 6 in 10 Black adults and Hispanic adults report difficulty affording healthcare costs compared to about 4 in 10 white adults. And adults in households with annual incomes under $40,000 are more than 3 times as likely than adults in households with incomes over $90,000 to say it's difficult to afford their healthcare costs. And so you might know or just have learned that health inequities are differences in health status or the distribution of health resources between different population groups arising from the social conditions in which people are born, grow, live, work, and age. Similarly, health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. They are inequitable and directly related to the historical and current unequal distribution of social, political, economic, and environmental resources that we see in this country. And a commonly used example of these concepts is the maternal and infant mortality rates. So as you can see from the figure on the left, it's on the left. Yeah, okay. Well, 63% of pregnancy-related deaths were preventable from 2011 to 2016. However, Black and Native American women have a significantly higher maternal mortality rate. Additionally, while the US is leading the world in infant mortality rate in general, Black infant mortality rate is about 2 times as high. As it relates to health insurance, you can see that 10% of Black women compared to 4% of white women had late or no prenatal care. Again, this issue is multifactorial, but the ability to pay for care based on your insurance status definitely is a contributor. Continuing with this conversation, a common myth is that being uninsured only affects those without a job, but in fact, in 2019, over 7 in 10 of the uninsured had at least one full-time worker in their family, and an additional 11.5% had a part-time worker in their family, which kind of dispels that rumor. There's also income inequality. Individuals with income below 200% of the federal poverty level are at a higher risk of being uninsured. And in total, more than 8 in 10 of uninsured people were in families with incomes below 400%. And while 41.1% of the uninsured are non-Hispanic white people, in general, Black, Hispanic, American Indian and Alaska Native and Native Hawaiian and other Pacific Islanders are at a higher risk of being uninsured than white people. These adults make up 43.1% of the non-elderly US population, but account for over half of the total non-elderly uninsured population. Additionally, Hispanic, Black, American Indian, Alaska Native, and Native Hawaiian and other Pacific Islander people all significantly have higher uninsured rates than white people. Again, just driving home this point, life expectancy is trailing in general, but there are clear racial health inequities related to this measure as well. And so a third effect of our broken system is delayed care. Even modest co-pays and any barrier to accessing care can deter patients from seeking life-saving treatments. As you can see, breast cancer treatment at all different stages, there was a delay in care based on your deductible amount, and there was a similar situation for diabetes management, which we'll get to in a couple slides, but there is like an increased death because of lack of health insurance, and this clearly, feeds into it. If we're delaying care for something that we should be able to prevent and definitely manage, such as diabetes, the burden on, like the death is going to be increased, especially when it's related to insurance status. And this figure continues to prove this point and shows that the breakdown of services most likely to be delayed. At the top of the list is dental services, which might also be in part because of the fact that dental insurance is typically separated from health insurance. Additionally, you can see that vision and hearing services are also delayed because these are not included under Medicare right now, but are definitely impacting our elderly population. And so for many US adults, prescription drugs are another component of their routine care. Among those currently taking prescription drugs, 1 in 4 say they have difficulty affording their costs, including about 1/3 who take 4 or more prescription drugs. And the high cost of prescription drugs also leads some people to cut back on their medications in various ways or to try to obtain medications outside of a clinical setting. About 1/4 of adults say they or family members in their household have not filled a prescription, cut pills in half, or skipped doses of medicine in the last year because of the cost, with larger shares of those in households with lower income, Black and Hispanic adults, and women reporting this. And so, as I mentioned, in states, again, one of the effects of our broken system is unnecessary death. So in states where uninsurance rates are high, there are relatively high excess death rates due to uninsurance. And in general, 50,000 people die due to uninsurance. And not surprisingly, the US has the highest rate of avoidable deaths compared to other OECD countries. And so this kind of brings us to a point of like, what are the main drivers of high healthcare costs today, and how are they controlled? So could it be that patients are utilizing the hospital too much? Patients are in the hospital for too long, patients visiting the physicians too much, the aging population in the US. And the article image on the right is by Dr. Gwande, which we just read one of his books, if you're an M2, and they this talks about the concept of super utilizers of healthcare, otherwise known as hotspotting. And it kind of is the idea that if we focus on the subset of the population that is using the healthcare the most, for whatever reason, that we can focus on them and shift it to a better, more comprehensive approach that is providing better care in order to kind of reduce the cost. But this is kind of limited in the fact that it doesn't address that the central reason healthcare costs so much is because the unit price of healthcare is high, aka the costs are high because the prices are high. And the video that I'm about to show kind of like breaks this argument down. So hopefully this works. All right. I don't know how to. Yeah.
I cannot tell you how obsessed I am with this chart. It shows exactly what is wrong with America's conversation about healthcare. On one level, you've seen this chart before. It shows healthcare spending as a share of the economy of a bunch of countries. There's Germany and France and Japan and Canada, and oh, there's America. But now I want to add something you haven't seen to this chart. This is how much of that spending in each country is private and how much is public. Here's what's amazing. America's government spending on healthcare, on programs like Medicaid and Medicare and the VA, our versions of socialized medicine, it's about the same size as these other countries, these countries where the government runs the whole healthcare system. And then there's our private spending. It's the private insurance system that makes healthcare in America so expensive. Conventional wisdom says the government is more expensive than the private sector. It can't say no, it's corrupt, it's inefficient, it's slow. You want something done right, you give it to the private sector. That is what we hear in America all the time. And yet here we are with the biggest private sector spending the most. Why is a free market so bad at controlling the cost of healthcare in the United States? If you look at the data on physician visits and hospital discharges, you can get rid of one theory. Americans don't consume more healthcare than people in these other countries. We don't go to the doctor more than the Germans or the Japanese. In fact, we go to the doctor less. The difference between us and them is that we pay every time we go to the doctor for everything from an angioplasty to a hip replacement, from a C-section to a pain reliever. In America, the price for the same procedure at the same hospital, it varies enormously depending on who is footing the bill. The price for someone with public insurance like Medicare or Medicaid is often the lowest price. These groups, they cover so many people that the government can demand lower prices from hospitals and doctors, and they get those lower prices. If the doctors and hospitals say no, they lose a ton of business. They lose all those people on Medicare, all those people on Medicaid. But there are hundreds of private insurance companies, and they each cover far fewer people than a Medicare or a Medicaid. And each one has to negotiate prices with hospitals and doctors on their own. And if you're uninsured, you have even less leverage. Nobody is negotiating on your behalf. So you end up paying the highest price. One study found that most hospitals charge uninsured patients 4 times as much as Medicare patients for an ER visit. Other countries, they don't have this problem. Instead of every private insurance company negotiating with every healthcare provider, there's just this big list. Country, the central government, they go and they say, if you want to sell to us, to all of our people, then here's what you can charge for a checkup. Here's what you can charge for an MRI or a prescription for Lipitor. And so then whether that bill goes to the heavily regulated private insurance companies in Germany or directly to the government, like in the UK, each country is telling the doctor or hospital or drug company how much that bill will be. And because the government controls access to all of the customers, it's an offer that hospitals and doctors and pharmaceutical companies typically can't refuse.
I'm going to make them an offer again.
In America, the idea is that you'll be a consumer, that you'll do what you do when you go to Best Buy and buy a television. But that just doesn't work in healthcare. It doesn't work in healthcare because you often come and get healthcare when you're unconscious in an ambulance, when you're scared, when it's for your spouse or your child. It is a time when you have the least bargaining power. You are not usually capable of saying no. You're not knowledgeable enough to do it, you're not comfortable doing it, or you're not conscious enough to do it. That's why in other countries, the government is a person who can say no for you. You can say, no, that's too expensive. You're going to have to lower your price, because they do have that power.
A new push for single-payer healthcare right here in the U.S.
California and others are saying maybe we should adopt the European model.
If we decided to create a single-payer system with one of these huge price lists in the US, there'd be nothing to stop lobbying from hospitals, from doctors, from drug companies, and those prices would get influenced. So we could end up with a single-payer system that is expensive, even as expensive as our current system. It all depends on how much you negotiate down the prices. And now in America, these groups have so much power because they are so rich that it's really hard to get them to bring down the prices. This is the irony of American healthcare. It's so expensive that it's become hard to make it cheaper. All that money they make, that becomes political power, and years and years and years of overpaying. Those are huge industries now, and they have a lot of influence in this. Under a single payer system, if we did drive prices down, doctors and hospitals, they would be paid less than they are right now. That might mean some of them close, some go out of business, or some move. It would be really painful. One person's waste is another person's essential service or local hospital or their income. But then single payer, it's not an all or nothing choice. For instance, there's a really interesting section of Bernie Sanders' Medicare For All bill where he lays out this interim plan. It's a plan he wants while he's setting up his new single payer system. And in that plan, he expands Medicare to cover vision and dental, and he opens it to nearly everyone. not just people 65 and older. All kids go on Medicare automatically, and most adults can buy in. That plan on its own, it wouldn't get American healthcare spending bar down overnight, but it would at least begin to recognize what we already know and what most other countries already do, that healthcare is one of those things the government can do cheaper and better than the private sector.
All right.
I cannot tell you.
Okay. So he definitely explained it like way better than I did and more eloquently, which is why I added that in there. But just again, to kind of reiterate his points, this shows that one of the arguments is that, you know, we're staying in the hospital longer. I mean, as you can see, that's not really the case. We don't particularly use more healthcare than other countries, with a few exceptions of certain procedures and tests, but we're going to the hospital the same or less in comparison to other countries. And again, the argument was maybe that we're going to the doctor too much. And again, not really the case. We're going to the doctor much less in other countries. And if you look, Japan actually is going to the doctor almost 3 times as much. But if you looked back at previous slides, Japan spends about half as much per capita, but one would say that they're utilizing more, but they're spending less. So clearly the cost of going to the doctor is not what's driving the cost of our healthcare here. Again, so this is just showing that 1.4% of the population is receiving long-term care, but that is not more than other countries, which again, just kind of disproves the point that people that need long-term care for whatever reason are driving healthcare costs in America. Continuing on, again, one of the arguments I posed earlier was that the US has more elderly people, which typically is a population that would cost more just naturally as you age. More things, you know, pop up. Your health just naturally again deteriorates, and you need more care, which could be, you know, a driver of cost is just more care. And then if there's more people needing more care, that would be higher. But again, this isn't really the case. Once again, if you look at Japan, they have a much higher percent of their population over the age of 64, but again, they're spending less than us per capita. So why are costs so high? So if you look here, comparing the US and Canada, for the most part, it's really hospital billing and administration costs that are contributing. So, you know, hospital billing and administrative costs are significantly higher. Physician billing related expenses again, and overall admin cost per capita. The US is spending almost 3 times as much on these overall admin costs when comparing to Canada, and about 1/3 of our total healthcare spending goes towards administrative spending. And so this is kind of something that I posed earlier, is that there are some procedures that we are overutilizing that might contribute to costs being high. And so as you can see, when it just comes to MRI scans, which is one of the things that they use, this isn't necessarily the only thing that we're overutilizing. But the way that we kind of practice medicine is to just add potentially unnecessary tests and procedures that just increase the cost of a healthcare visit. And that's kind of the way that we practice medicine, unfortunately, is, you know, including these things to kind of like rule out the what ifs. But even though we aren't the highest measure of MRI utilization, we still tend to overutilize this procedure, which can contribute to unnecessary costs. And as you can see, MRIs cost over 5 times as much as it does in Australia, and there is stark variability in prices. So an MRI can cost a different amount between different hospitals. There can also just be variation in prices unrelated to MRIs, that it's the same hospital, but the same procedure just costs a different amount. So there really is no regulation on the high prices and like a set standard. And this kind of drives home the point that prices are high because, or costs are high because the prices are high. American healthcare spending is higher than other nations. It has nothing to do with having a sicker population or greater healthcare use, which is something that the video again talked about. And it's because health insurance companies can't really negotiate a good rate when they have like a fragmented healthcare and are only having smaller risk pools, where, like the video says, a single payer system would be more equipped to control the costs. And so this kind of wraps up the discussion. So today we covered the state of affairs in our current system and the effects of this broken system. And please come back tomorrow because we're going to continue this conversation. And Mike is going to go over the Medicare for All bill that is currently being proposed. And more importantly, like I said, he's going to go over why this is kind of the solution to all the problems that we pose today. And then on Thursday, the two of us are going to be myth-busting the major arguments against universal health care and also ending in ways to get involved with their organization. And finally, there is a SNaHP festival on Friday, and we welcome everyone to attend. However, if you are interested in getting involved right this very second, the last couple slides will be talking about ways to get involved. And also coming up in the near future, sometime in early October, we will be having a panel on the experiences without insurance. So a lot of the time people, I'm not saying anyone here, but in general, people have a hard time supporting or seeing the effects of uninsurance and supporting universal health insurance because people in their bubble haven't necessarily experienced something like that. And so this panel is meant to kind of open people's eyes and realize that a lot of people are experiencing uninsurance and kind of the effects that have on their life. And with that, like I said, this is a way to get involved, and just thank you for coming today, and we'll see you tomorrow.